Thank you very much, Deb, and our participants. I would now call the participants in our second debate forward. And as they come up, let me introduce Holly Weiss. Holly is going to facilitate the second debate. And again, I thank you for pinch hitting on short notice for Maria. We're glad to have you, and please welcome.
Good afternoon. Welcome to the second debate on envisioning the new workforce. Our proposition is a little change from your printed program, and once it gets up, it'll state that it focuses on task shifting and asserts that the creation of new task-specific roles should be the strategy for health professions to meet individual and community needs. So now, I want you to take a minute and place your vote, and if you're a little uncertain what that means, I'm going to go ahead and describe it a little bit as an introduction, and then we will turn to our debaters and reactors. Task-specific roles and task shifting is a recent term that has developed from the need to address chronic workforce shortages and involves scaling up of the health workforce through the rational redistribution of tasks among health teams. Specific tasks are moved, where appropriate, from health workers with longer training and who may be more qualified to health workers with shorter training and perhaps fewer qualifications, or transferred to non-professional qualified community members. The purpose of task shifting is to make more efficient use of the available human resources for health. It should not be associated with second-rate services, and it really should be a means of improving overall quality of health service by moving increased human resources closer to the communities where their services are needed. Although a recent term, task shifting and training for specific roles within professional health teams has a long history from which lessons can be learned. I'm sure many of us all know the example of writing routine prescriptions being shifted from physicians only to other healthcare professionals. That's just one example. Another example is in 2006, the World Health Organization launched a task-shifting plan that involved training non-professionals and retraining mid-level health workers for specific roles in response to the HIV/AIDS crisis and the workforce shortages in areas around the world. In addition, many people with chronic conditions such as asthma, diabetes, etc., have been trained to manage their own disease on a daily basis, requiring less care and having better health outcomes is another example. And in addition, these individuals have been trained to be peer navigators in some cases and tutors, offering a valuable service to the health team. So task shifting or task-specific role training represents a departure from traditional delivery models that depend on specialist workers, but it could also make a major contribution to expand access to services. A changing world demands a changing healthcare system. Today, with the explosion of information technologies and the growing body of knowledge of health sciences against the backdrop of low health literacy levels, imagine the possibilities of services that healthcare professionals could provide if the tasks of attaining medical histories, interpreting medical terminology, concepts, and patient education were shifted to non-professional IT workers, for example. Just imagine what other new responsibilities or tasks could health professionals provide. So task shifting and role-specific training is proposed as an efficient approach to scaling up our workforce, but it's one that must overcome significant challenges. This strategy could reduce cost in certain circumstances, but it requires new resources and infrastructure. A system of checks and balances involving credentialing, regulation, and legislation, just to name a few, is needed. Quality assurance mechanisms need to be put in place to protect the people receiving the care, as well as the health workers themselves. Key elements must be in place to ensure that this strategy is safe, efficient, effective, equitable, and sustainable. So hopefully you voted by now, right? If not, are we finished voting? So now you know the overview.
Debate number 2. Got it? Yeah. You raise it. Yes.
So the overview for the format, while you're voting, I'll just talk a little bit to take up the time, is first we're going to hear from Liza Goldblatt, who's going to speak in favor of this proposition statement. Then we'll hear from Elaine Tagliareni, oh, that's an Italian pronunciation, who's opposed to this proposition. And then we're going to get a reaction from Emilia Iwu, who's a Jonas nursing scholar from Nigeria, right? So has everybody voted? All right, let's begin.
Good afternoon, everyone. Actually, we've had a rather shifting topic over the last couple of weeks, so we finally settled on this one just last Thursday. So it's delightful to be here. And just as Rick was able to rest his case, I have to really thank Drs. Campos and Kaufman for this morning talks, because clearly we actually can do this. We're already doing this globally. So for those of you who were here yesterday, what you recall is that we provided evidence that over 50% of the health professional students and providers are actually burned out. And we went through all the issues around burnout and many of the ways that we might begin to address them, but it's at least 50%. On the other hand, we are living in a very high-tech world, and cell phones are everywhere, and there's access to anything. In fact, my colleague Jan just said to me, the reason they're so burned out is a high-tech world, and I would tend to somewhat agree on that. So the consumers, as you well know, as your patients or your clients, are coming in now with all kinds of material they've taken off the web, right? Different science articles, different research articles of various new treatments, and they're walking in and they're handing it to their healthcare provider saying, well, what do you think of this? And many of our providers simply have no time whatsoever to actually research these particular areas. In fact, I was just reading an article that says that if a practitioner reads 2 articles a night, by the end of the year, they will be 6,000 articles behind in reading on that particular condition. So that's just to get us ready for the next world. Yes, 24/7, someone at our table said, we'll be online 24/7. So yes, all practitioners, all health providers need basic technological skills, obviously with EMR, with evidence, with articles and treatments, but we cannot ask the current licensed and regulated practitioners to provide more. We just can't ask them to provide more. They're losing their tactile abilities with the patients. They're losing their communication ability. We all know the studies that are coming out that are saying when they go and meet with their practitioners, because of the EMR, are sitting there typing on their computers and not having contact with their patient. So we, and I will tell you who we is, we were told we could have humor in this. So there are 65 different healthcare fields, and we represent globally 580 national organizations. We have created 2 new, in a sense, they will be assisting us in easing the burden on the current licensed and regulated fields. One of them we're calling the Meditech, and the other we're calling the Community Health Liaison. And their role will really be to ease the burden on our current healthcare providers. And they will very much be curtailed to the rural, urban areas, and each community will decide what it wants. So thank you very much, Dr. Kaufman and Dr. Campos. And they will also be very much culturally relevant to their particular areas. They will also be an integrated part of the healthcare team. They will not be separate from the healthcare team. They will be familiar with their community. They will be trusted. They will be respected. And they will have IT skills. As we already know, the healthcare workers and liaisons already exist throughout the world, and I'll give a few examples of them at the very end. So they will need to be trained in certainly no red flags, enough about healthcare, and also they will train all the licensed healthcare workers about what they do in the community. Significant emphasis will go on referral when it's time to refer. So the Meditech could actually monitor emails that are coming in from the patient persons to the practitioners, and the Meditech will actually begin to collect the material. And if, for example, they wanted articles about their condition, then they could easily send those articles. That doesn't have to go to the licensed practitioner. If they wanted evidence, the Meditech could be trained in credible evidence, and so on. They could explain term, they could explain philosophies, and they could offer the patients and the clients a significant amount of information on their particular conditions and diseases. Now, those of you who know me know that my passion is about self-care, resilience, health, and well-being. So another role of the Meditech will be to get information out quite frequently, because we, at least in this country and in many countries in the world, know that 75 to 85% of what we're spending in the healthcare dollars are for preventable conditions. So why can't the Meditech just send out little bleeps now and then of, have you taken your walk today? Have you been in nature this week? What have you eaten today? I mean, this could be a wonderful role for the Meditech. And some patients with difficult chronic cases need more frequent communication. So the Meditech would also have to be trained as a trainer. I know we're starting to burden the Meditech, but that's all right. So we now have Fit bands and we have Apple Watches, and there are all kinds of ways people are self-monitoring. Well, another role of the Meditech would be to gather all that data and always look for the red flags when it has to be forwarded right away, analyze it, summarize it, shoot it off to whoever the main provider is, and then the main provider periodically would call the patient and have a dialogue with the patient in terms of how their progress and health are going. So now I want to talk for a moment about the community health liaison. And again, I can only speak living in the US, although I did spend 2 years over in India, but we tend to be a little what I would call ethnocentric, for those of you who are familiar with that particular term. And I want to give you two very concrete examples of why the healthcare liaison and healthcare worker are actually so crucial if we really want healthcare to be accessible to people throughout the world. So when I landed up in Rumtek Sikkim, a tiny village of 600 that was basically overseen by a spiritual leader, there was no healthcare there whatsoever. And people thought of the hospital as a place to die. That's how they thought of the hospital, and they wouldn't go to the hospital. Am I over time, Holly? Oh, okay. I'm going to take 2 minutes. Oh, I'm way over time? Oh, the red flashing light. Oh, that happened to me once before at the IOM. I was wondering. Well, I have to finish this one story. And so, and basically what happened is that people only went to the hospital and they waited too long. They had a ruptured appendix and then they died. Well, the other group ended 5 minutes early, and we have one person missing, so we're okay. So what happened was I went and met the lead physician over in Gangtok, Sikkim, the capital of it. I was doing field work for my PhD in medical anthro. And he happened to be a student of the spiritual leader. And so he agreed to come over, train a lay midwife, and a lay nurse, in a sense, who the community trusted, who they respected, who would actually be paid by the community itself and the government of Sikkim. And that is still going now. Well, I'm going to disclose my age. That's almost about 30 years ago. And it's still going today. But it was the only way we could get health care into that community. So I think we cannot be ethnocentric when we're really looking at what are all the different possible roles of the community health worker. And one last one, on the Native American communities, we have found that the people that work in drug and alcohol are very easy to train in what's called a 5-year protocol for using acupuncture that actually reduces the cravings of the drugs, and their recidivism rate is significantly better. So thank you, Dr. Campos and Dr. Kaufman. I didn't have to spend as much time on the community healthcare worker because you did it for me, and I'm so sorry I went over time.
Well, good afternoon, colleagues. I'm here to support the negative position here, We do not need the creation of new task-specific roles for the healthcare workforce. I'd like to start by telling you the story of Eva that was described in the most recent Health Affairs for March 2015. Eva was met outside a healthcare clinic, and in the past year it was discovered she'd had 9 ophthalmology appointments, 5 radiology, 4 pulmonary, 4 incontinence, 3 for cancer, 6 to the ER, and 12 missed appointments. Eva's story tells us that we have fragmented care, limited effectiveness of clinical practice. Here's my conclusion. We don't need more task-specific healthcare professionals. Heck, we have that already, and it's clearly not working. What we need is comprehensive realignment of the current workforce, refocusing of that workforce, and a redefinition of those roles to get to the point where evidence-based practice really informs their practice. 1 year later, Eva now has 3 people caring for her, a nurse, a social worker, and a geriatrician, and a carpenter who was brought in to get her a ramp. What's that telling us? That what really made the difference was integration of services, team effectiveness, all the things that we've talked about in this conference. What's driving this need to move healthcare workers to this refocusing, not new roles? Certainly the rise of consumerism, the authority that many patients take now for their treatment alternatives. Now, there are many pockets of innovation, but the current workforce, in most cases, is not trained to meet those needs and to understand technology in a way that consumers are demanding. Secondly, healthcare now, we know, is an information-intense activity. It has to be. All healthcare workers need technical and knowledge management skills in order to evade. If we assign those skills to an IT specialist, then we're moving that, we're not assuming our authority or our integrity related to those roles, and we'll create more silos. Collaborative practice is another driver, and certainly the move to primary care. So what's this telling us? That these drivers call for the realignment of services provided by our current workforce to bring them up to speed. Because, colleagues, whole new task-specific roles will only lead to more silos. And we have some international examples. Holly told you about the WHO report. There's also the Helping Babies Breathe Global Development Alliance in Tanzania. This has taken the existing nurse midwife population of Tanzania, continue with their current role, but bringing evidence to that role by teaching them 2 specific tasks, that maternal mortality caused by hemorrhages, neonatal mortality, decreased breathing. And so we taught them those 3 evidences, and in 2009 to now, there's been a 47% decrease in neonatal mortality due to this specific intervention. So refocusing the current workforce, not developing new ones. This workforce already had an alignment with the community. So at a time when the world is facing a shortage of health workers, the focus needs to be on policy and practice initiatives to bolster the current global nursing workforce, to retrain them, direct that care, but not develop new roles that can only lead to perhaps more fragmentation. Let's talk about Eva today. She has those same comorbidities. She's even more frail. The comorbidities are even more intense. But guess what? She's healthier and waiting for her 95th birthday with great anticipation. So my point today, colleagues, and why I need you to vote no on this proposition, is that the danger in creating new roles is that we may be creating new silos, and that's what we need to do. So trust me, colleagues, your future depends on voting no. Thank you.
And now Emilia Iwu will give us her reaction from Nigeria.
Okay, so this is an area, Nigeria is among the sub-Saharan African countries, and the WHO has really kind of said that they have to adopt this way of doing care. So well, they went from calling it task shifting to calling it task sharing because it created some problems among the health professional groups because they thought they were handing over all their roles and they wouldn't be able to take it back. So that created a threatening environment. So they call it task sharing. So it's not new, like they said. Over even pre-colonial and colonial era, they've been training people to be task specific and perform certain roles in that country. However, the name task sharing came about because of what they described. So it has advantages. In Nigeria, it created employment opportunities for community workers who ordinarily were not employed, so they had tasks moved over to them, and they were able to perform roles like in HIV, they used the patient population, or the clients themselves became people that will help to in counseling for adherence. So they had opportunities for jobs. So it motivates and empowers the new cadre to enhance their role and worth within the community. Availability of services in hard-to-reach areas, this really helps it. However, also it creates access to services and care closer to the clients' homes. Many of them didn't have to travel so far to be able to get help. All right, so knowledge and skill help to save many lives, and it prevents diseases too, because some of these providers can do a lot of preventive activities in the communities. Examples include immunization. You mentioned help babies breathe. In Nigeria, we have obstetric life-saving skills, prevention of mother-to-child transmission of HIV. Okay, so where collaboration and teamwork really exist, this is really a perfect mix. It's cost-effective. In short, cost-effective mostly in the short term and the mid-term. The long term, we're yet to see. Awakened, oftentimes these providers, you awaken their interest and desire to become healthcare professionals. So many of them go back to school, become doctors and nurses and the other practitioners. So this is really good. However, it has disadvantages. So some of the disadvantages is that there are plenty of regulatory issues. Oftentimes the regulatory issues lag behind the role creation. So if we're doing this, if you vote yes, you have to convince the policymakers to really adjust the regulatory issues before you do it. Because there is a lot of tough protection and limitation and control over what knowledge is given to these providers. Oftentimes it could be very dangerous because if we give them half knowledge, and when they're presented with situations beyond that knowledge, then it may do harm to the patients or the client. The capacity to address health situations may be limited, especially when there is a clear obstacle to appropriate referral to the next level of care. Attempts to practice beyond scope without remote or face-to-face guidance, if there is no mentoring or connection to a higher level provider who can guide them through situations when they can't move patients, it becomes a dangerous situation, especially when the patients cannot go to the next level. So sustainability often is a challenge, especially if you create this role in a parallel environment where it's not integrated into the health system. So when your money goes away, the role kind of dies away. So sometimes, if no longer supported, the role fizzles and there's a waste, and in short, those people have those skills, but they're no longer using it. So overall, it is an arduous process to incorporate a new cadre into civil service structure. You need to carry policy makers along from the planning stage, and it may take years to do this. So if you have a fast-track mode, use it. Forming an alliance with key players in the health system is usually something to ensure that you do right from the beginning. And you can use those key players who you have brought along to your side to now create policy changes and scope of practice adjustments. So that's I'm still not supporting either of them. So, but this is the experience we've had in Nigeria. So, but it's been very helpful.
Thank you, Emilia, for your very thoughtful and reflective comments. And now, colleagues, it's time to re-vote. And while you're re-voting, we can open it up for discussion. And at the end of our discussion, we'll ask our debaters what they really, really think. Yes, Susan?
This is more a comment or a question, because my interpretation from your conversation was that we were talking about task shifting primarily in the sense of things. There was a time when only physicians could administer a vaccination, and that's no longer true. So that the tasks could shift and the higher levels of training could focus on areas that required all those years of expertise and so on. But then in the debate, it was kind of talk about both ways, creating new roles as well as task shifting. So those are two different propositions, and I think it may have confused the vote a little bit, but we'll see. I mean, in the Khan case, you were agreeing in many ways with the idea that people can take on tasks that say a nurse practitioner can do things that in the past only a physician was allowed to do, and so on.
Right, so
yeah.
thank you, Susan. Lisa and I are saying that it's because we shifted our debate proposition. So when Holly was starting talking about task shifting, so we took varied definitions of it, the creation of new roles, because in our initial conversation, it was really about new role development of IT specialists, technology and IT specialists. But so we're thinking that the broad definition of new roles is both shifting and new roles.
And I really do think it's consistent with the changing environment. We're going to have changing roles. So that's evolution and the acceleration of technology. So it actually is, that's why they're both covered in this debate today. Yes, Malcolm.
I wouldn't worry too much about that. Voters are always confused. So I think you did a perfect job of setting the stage.
Isn't that the point, Malcolm, to get them confused, right? Okay.
I actually thought Emilia completely supported my case, but then she said she's neutral, so now I'm confused, so you know.
Any other comments? Yes, Afaf, and then we'll come to Jan. Jan first.
Jan.
I think that for me, the most important thing is that what I see actually in healthcare, and maybe it's different in other countries, but in Europe is a problem, is that healthcare professionals tell me at any level that 20 to 30% of their time, they are doing things for which they are overqualified. Right. And that's, of course, an enormous waste, not only of money, but also of experience. It's eroding the capacity of your healthcare workforce. If specialists don't see enough complicated cases, you erode their competencies, but also those of, for instance, the family doctor that doesn't even see dermatological problems because they go all straight to the dermatologist. So I think that's really an issue when you look at efficiency, which we discussed this morning. Second point is of course, well, in Belgium, 90% of all the cervical cancer smears are done by gynecologists. So what should you do with that? That's, of course, not needed. It's a repetitive action. You could bring it to the family physician, but also that would not resolve your problem. You can bring it to the nurse or to the midwife. So, but then you have to discuss with the public, because the public has to accept and to play that. So when we shift roles and tasks, we have to involve the public. I think that's extremely important. If not, you will have a clash with confidence, and that will be negatively at all levels of. And by the way, in the future, probably the cervical screening will be a selfie, so people will do it themselves.
That's right.
And we're going to hear from Afaf then Sarita.
Pat Melis. So the debaters, first of all, did a fantastic job. And I disagree with all of it.
Yay.
And here is the reason. The word task is not congruent with individual and community health needs. Competencies are more congruent with what we really need to be doing with individuals and community. So that's one part. task shifting is also denigrating and it's downward from where it's supposed to be. But competency sharing is more conducive to teamwork, respect between members of the team, and a lot more congruent with what individuals and community need.
I like that, FF.
I would agree with
We
that.
like that,
yes,
and
thank you.
competency sharing, okay.
We were all agreeing up at the front that we liked the word sharing, task sharing, but I like competency sharing even more. Sarita, and then everybody at this table, and then we'll come back to Lemmy.
They want to do a group talk.
Okay.
I think there's a lesson to be learned from the fact that when a gap exists, something naturally grows into it. That's evolutionary. And so an example that I would give is that in the fact that with massive aging population in our country, in Canada, two things have happened which have naturally just evolved to meet the gap. One is the development of personal support workers, which originally came from other countries who were harvested and came as housekeepers or au pairs or whatever, and now have become actually something where you can get a training program and become a certified personal support worker, because most of our elderly actually do not have sufficient care from the social system to be able to provide that care. The other, in fact, related to that is the arising of a new profession that's called the advocate navigator, the patient navigator, because again, a lot of either illiterate or non-English speaking individuals arrive in acute care settings or in community care settings, and they are unable to actually advocate for themselves and navigate a complex system. And then the third thing, it goes to what Afaf said about life-work balance for women, is that the daughter, daughter-in-law, and wife who end up actually becoming predominantly, 90% of them are the caregivers for their elderly parents, have acquired a skill set, which I think needs to be acknowledged and almost given a credential of some sort, because it's a task-specific role. These are all roles that have arisen as a result of need. So whether you want it or not, be it robots or meditechs or whatever, unless the professions themselves rise to meet those needs, something naturally will grow through the cement and actually try to address those problems, because people are otherwise going to fall through those cracks.
Well said.
Beth?
I think that that's one of the most important pieces we as educators need to embrace, regardless of the discipline. And that is, how do we educate the next generation, and even harder, the current practitioners of our discipline, that we are more than the sum of the tasks we do. And that this new group coming through our programs need to be educated to how they identify those gaps, and then how can they be flexible and work with other members of the team. So those interprofessional competency pieces clearly become one of the most important things, because this is going to keep shifting. Today it may be care of the elderly or working with patients with HIV. Tomorrow it will be something else. And I'm not sure we teach our healthcare providers how to identify these needs, the gaps with the work we have to do, and identify the best person with the skill set, the competencies to do it. So I think that becomes a requirement for us to consider, is how do we educate for this constantly changing environment.
Thank you. Chris, Mary Joan, and then
Thank you. I think my challenge with this proposition is the word "and" at the very end. I think that those of us who have been fortunate enough to see examples from around the world of community health and well-being understand that in community settings, it's often very, very advantageous to have what we in this country would call non-traditional community health workers, because fundamentally traditional healthcare providers are not very well trained in community health, certainly not in community health assessment from a population or public health perspective. But from a patient's perspective, I can tell you that the last thing that patients want to see, I believe, is yet another person with a further confined set of activities that they undertake on behalf of your care. And again, that blind person in the room with the elephant just keeps getting bigger and bigger. The more people that we have providing smaller and smaller pieces of non-integrated care. So I see the proposition very differently with the word individual versus the word community.
Interesting. Mary Joan, and then Dr. Campos, Francisco, yeah. And then Lemmy.
So just two comments. I wonder if we could stop using the word non in terms of professionals and just call people who they are. So you're a lay health worker, you're not a non-professional or non-health professional, you're a lay health worker.
Good point.
Second point is, as we've gone around the country looking at primary care practices and creative use of the workforce, many primary care practices are looking at task sharing. But there's an issue that arises in terms of social justice here, because many of the lower paid workers are sharing tasks with the higher paid workers, but they remain the lowest paid workers. So in primary care settings, medical assistants, for example, are taking over wonderful jobs and being trained for them. So many of them are taking over motivational interviewing and coaching in the practice and have great career ladders, but they're still extremely low paid. And but the professional workers are still very well paid, and we should pay them well for what they do, but we should also pay those that are at the lower end of the wage scale, increase their wages if we're sharing tasks with them.
I think you need to press that button for the red light.
There are quite different propositions, because one thing is increasing the silos, increasing the complexity, making new professionals, increasing the costs the world cannot afford. You, as the United States, can, but the world definitely will have problem if we make this thing much more complex than it is already. But the other things is considering there in some places, and I saw many countries in the world where, for instance, community health workers cannot vaccinate because there is a non-flexible regulatory framework that does not allow, for instance, nurses refilling prescriptions, or vaccines cannot be done by other professionals. So I think that task shifting in the I know the WHO document is completely different in a country where you have a lot of surplus of health professionals, and other countries where you don't have health professionals. So in such, for instance, in Brazil, we have been trying to make that some diseases that are quite well established, for instance, the auxiliary nurse can refill the prescriptions, but the regulatory framework, especially by the physicians, is quite rigid about this. They prefer people not having treatment than having other professionals allowed to do the refilling the prescription.
Good point about the differences in the environment, making it complex, much more complex.
I think that we clearly need to make sure that we're continuing to educate individuals who can think on their feet and who are aware of all of the resources that are available to them, and they can make efficient decisions around what it is that they're doing, and they clearly will be able to certainly practice based on their competencies. But I don't think we should be moving towards developing new tasks. We have more than enough work that people are engaged in. One of the challenges certainly is around practicing at the top of the license and not engaging in those activities that someone else can do. But if that someone else is not there, then you do need to do it. So I think there is a balance between making those decisions and knowing when you should do what, and again, always only doing that you're competent to provide.
Well, what a rich discussion. Thank you for stimulating it. And before we find out how you really feel, who wants an update on the vote? I know, Sarita does. So I don't know if we're able to get that up there. Okay. Oh, wow. I bet if we voted again and voted often, we could change it again right now. All right. Elaine and Liza, tell us what you really, really think.
Okay. Well, I actually think it's somewhat of a both and it really does depend on the environment. So the element to me that we all need to analyze is what will work in what communities. And so I think that's very crucial. I think for all of us that primarily work in the licensed, regulated healthcare communities, we truly need to be self-reflective of where we are with what I would call the tie issue, which is turf, ignorance, and economics, and really start to think about, are we willing to put the patient first, the person first, and really think about what's best for the community, obviously keeping in mind the issue of safety and quality. So the idea of community healthcare workers, or even a Meditech, is really not to fragment the system anymore. It's actually to try and make it more cohesive, because those individuals would be a very integral part of the team, and indeed will be trained to be part of the team. And we have to look at the issues of remote and rural areas, as well as right here within this country, highly culturally diverse areas, you know, where we need significant translation, not just of the language, but in terms of what, you know, the individual in the white coat may be offering to someone from a very different country that is not familiar with our kind of sterilized healthcare system. So I also think that if we really want to flip to emphasizing health and well-being, and then when we need it, a sick care or disease-based, you know, care system, which is certainly required, many other people could be really trained to do that much more frequent contact of how do you stay healthy. We're not going to find the MDs calling a person or a patient who has very severe diabetes every day. It won't happen. So why aren't we looking at how do we promote health and well-being in very different ways? Again, I want to point out in Peking, the lay nurse there, they didn't have the regulatory issues, so the lay nurse there, you know, took all the vitals, did vaccines, and also went with the individual to the hospital as a translator. So we have to look at the environment. So I just want to emphasize that. I think they're really appropriate times for different kinds of practitioners, and they do need to work with the government and the culture and the regulators, but we need to find out what the community wants and needs and work with each one in a sensitive and appropriate way. Thank you.
Thank you, Liza. You know, I do think it's a hybrid, but when I think about what the solution, I mean, to your point, so many of you, that we have so many things we need to do, both in education and practice. Collaborative practice, I think, is where we need to focus ourselves, because to Afaf's point, it isn't so much about what tasks we're sharing, it's the competency that the patient needs delivered by that team. And so when we get into that mode of practice, then I think the roles will shift. We also need to educate our health practitioners and professionals to not own their role as it is defined when they leave school. Or leave their graduate program, because I think we hold on to the tasks as our definition of role rather than seeing it more broadly in the context of the total team. So I think team will function. And just a final note, I was walking to the metro this morning and I ran into one of my neighbors who was walking with me, and she said, "Oh, you're going downtown right near me? Where are you going? National Academies. What are you doing?" "Oh, I'm a part of this debate." "What's the debate issue?" And I said, "You know, we need to develop new roles." "New roles," she said. "Are you kidding? We just need doctors and nurses and practitioners to talk to each other. I was just at the doctor," and she went on and on. So I said to her, I said, "What are you doing at 2:15 today? Maybe we could use you." But the point is, the patients really know that we need collaborative practice. So that's our mandate, I think. Thank you.
Emilia, do you have any final comments? Do you want to vote now?
I think it depends on what the client need is and what the community needs from us. I think we need to be responsive as opposed to be restrictive to what we can do as a person or together. I think we need teamwork and collaboration. And with that, we will turn around how the patients feel or how the clients feel about the care that we give. So I think this has really helped the providers in Nigeria to look at their role. I recall working with the government system and trying to develop a policy on task sharing. And it was amazing how the turnaround among practitioners from even the licensing organizations that didn't really want to give up on any roles initially, and now they're really coming around and say, whoa, we could even do this. They took it further. So I think we need to let go, sometimes relax and listen to each other, and we'll make progress.
Well, thank you. I want everybody to join me in thanking our debaters and our reactors. I know I learned something new, so I appreciate everybody's thoughtful feedback, and I'll turn it back over to you.
Well, again, my thanks to Holly and Deb for coordinating our debates and to all of our participants. You now have an opportunity to stretch your legs, talk with your colleagues and friends, perhaps grab something to drink or to eat, and we will reconvene promptly at 3:30. Thank you.